interpretation of the OCT. Will not be going to the theory. So this is a report of an OCT of optic nerve head. So we can divide it into 8 sections, and if we go in an orderly manner, it will be good to analyze. So first the patient details. Second, the signal quality. Thirdly, we look at the tomogram. Then fourth, the thickness map. Then the significance map. Then the table, the optic nerve head and RNFL parameters. Then we look at the graphical plot of the RNFL layers. Then lastly, the sectoral analysis of RNFLs. So one by one. First, the patient details. In the patient details, we have to be sure of the age, because all these OCT measurements are color coded based upon the normative data. So if the age is different, we will be getting false values. So we should first check the age is correct. Then check for the quality index. If quality, this should be it's better. It's called good quality if it is more than 6. And at least a minimum of 4 is needed. If it goes below 4, it will be poor quality. The measurements can be. Then we go into the tomograph. Tomograph landmarks should be checked. So this blue line indicates the Brooks membrane, and the Brooks membrane opening is the machine dictates it as the disc margin, and this red line is the internal limiting membrane, and the ending of the internal limiting membrane here, it is considered as the cup margin. So the distance between these 2 points is considered as the minimum rim width. That's the concept of the OCT imaging. So we have to check this scan picture to whether these lines are correctly aligned. If there is any vitreous floaters or any hemorrhage, anything, these can be irregular. So we have to check to know the quality of the scan. Then coming to the thickness and significance map. Thickness map is the topographical map showing the correct values of the original measurements of the RNFL values, and it should be having a hourglass pattern, like hourglass. This patient is having superior RNFL thinning. So here it should be a red color, but it has gone to the green due to the superior RNFL thinning. This is a significance map. This is a first fundus image, and here the disc margin and the cup margin will be marked. We have to check that if it's correct only. Then the color coding is there with the p-value significance. If the p-value less than 5 is color coded as yellow, and red is when the p-value is less than 1. So we will get the damage, the thinning in the significance map. This is the easiest part to look and see if there is any RNFL defect. Then we will check the tables, the optic nerve head parameters, and the RNF factors. The 3 most important things are the luminary, the vertical CD ratio, and the average RNFL thickness. These 3 are the main important. All these are color coded based upon the percentage. Where yellow is less than 5% and red less than 1%. So always look at the average RNFL thickening, because that's the most specific and sensitive indicator to check for glaucoma progression. Then the graphical plot. The RNFL graphical plot, it is also color coded with green normal, yellow and red danger zones. Then we will follow the line and see if it dips into the red areas. Here it is just a border line in the right eye, the superior RNFL area, but all others are within normal limits. In the left eye, there is a obvious dip into the red area at the superior. That's the as shown in the previous picture, superior RNFL thinning. And the middle picture shows the RNFL layers of both right and left. And if there is any asymmetry, we can check in the middle figure. Lastly, the sectoral. In the sectoral analysis, the RNFL values in the Glaucomas and quadrant wise is given. In the Glaucomas, even the smallest and earliest detected defect can be detected, which can be ironed out in the quadrant wise. So this is the double hump appearance of the OCT RNF. So this is all the regions for reading the OCT report. Now the confounders in OCT, as ma'am already told, floaters can affect. If there is a floater, I will show the next picture. It's from an article. Here this patient, it is same patient's OCT, different times OCT. Here there is a floater in the area. The OCT measurements are taken in this circle. It's a 3.4 mm circle centered at the optic disc. The RNFL measured in this circle. So if now this vitreous floater is outside that circle, at that time the RNFL values are normal. When the floater entered this circle, at that area they are showing RNFL thinning. And when again the eye is moved, the vitreous floater again changed position to 6 o'clock, the RNFL thinning changed area. So the floaters, we have to always check the first fundus image if there is any vitreous floaters in the measurement area. Similarly, blinking artifacts. If the patient blinks, that much area won't be scanned. This also can affect the values we will be getting. And also motion artifacts. If the patient moves their eyes, there will be defects we can see as the breaking of retinal vessels. But these blinking artifacts, this motion they are rarely seen in the newer machines because the acquisition times are very less, 1 second or something, and also good eye tracking systems are there. So these are rarely seen now. Then there is a floor effect. Seen in the advanced glaucoma, the machine cannot detect an RNF thickness less than 50 microns. It is due to the residual drive tissue of the optic nerve. So in advanced glaucoma patients, we can't use the OCT for analyzing the progression because the value will plateau at the 48 or 50, that range. So advanced glaucoma patients, only visual fields are significant. Now the OCT ganglion cell complex. The ganglion cell complex includes the inner plexiform layer, ganglion cell layer, and the retinal nerve fiber layer. The inner plexiform layer means the dendrites of the ganglion cells, and RNFL is the axons of the retinal ganglion cell. So basically, glaucoma means retinal ganglion cell death. So this GCC can also be used to detect glaucoma, and it's useful in many conditions. Apart from glaucoma, like this is the scan. This is the optic nerve head scan of the patient, showing superior and inferior RNFL thinning. This is the same patient's macular GCC, showing the GCC thinning. So it's useful in a glaucoma suspect patient. In this patient, the patient had high teens IOP, and fields were some peripheral points but not corresponding to the OCT scan, but OCT scan showing a minimal early like RNFL defect. So to confirm if it is a defect only or the machine dependent, we can do a GCC, and the GCC also corresponding small defects are present. So this patient is going to glaucoma suspect. These patients should be aggressively monitored, observed. Early detected. Then in high myopia, we will also always see high myopia. There will be RNFL thinning. So there will be confusion. Actually, there is no true RNFL thinning in such patients. It's due to a phenomenon called ocular magnification. Ma'am told if you adjust the circular area, we will be able to correctly get. I have never checked in this machine. I will see if it is possible. Otherwise, the 3.4 mm circle on a larger area will be larger. So the RNF will be, it's not true RNF thinning, but it can be considered as an RNF thinning. And also another thing, this in high myopic patients, the RNF fibers will be shifted temporarily. So when in the graph plot, we can see as a false increase in the temporal quadrant and thinning of the superior and inferior quadrant. So in such patients, it will be very difficult to diagnose glaucoma. In such patients, macular GCC is considered good, is less influenced by these items. Then another is preperimetric glaucoma. With the advent of OCT, we are diagnosing so many preperimetric glaucomas. Preperimetric means the patient is having raised IOP, disc changes, but visual fields are completely normal. So this is patient, a 51-year-old female patient. Her vision is 6:6, IOP is 18:18. Right eye with a 0.7 cupping, left eye 0.4. She had thin cornea with a CCTs of 458 and 454. Her visual fields are normal, but OCT shows a thinning. Here the inferior RNFL thinning in the right eye and left eye superior RNFL thinning. So actually in the treatment of preperimetric glaucoma, I would like to have your opinion. in such patients, what I do is I give the option to the patients, even observation or can start medicine, and based on their rapport I will do it.
That's better actually. And if the patient is less likely to come for follow-up, you can start a medication also. Like after 2 years only they will come back. Better if you are able to check in between, it's okay. If you are not able to follow up in between, option better to give to the patient. Six months will be more than 1 to 2 times if you are checking and it's stable.
3 months.
3 months. First baseline for the patient to get the to do the. In the first year we can do as early as 3 months. 6 monthly. If the patient is stable, only yearly is needed.
Initially,
learning curve
Fields.
Stable OCT yearly. And lastly, the glaucoma progression. So in the OCT, the glaucoma progression is detected by if the RNFL is decreasing more than 1.7% per year, and if the GCC is decreased more than 1.3% per year. And the RNFL is, you can see the percentage 1.7, 1.3. So 1.3 for faster rate of loss for the RNFL. So it is the best indicator, sensitive and specific for the glaucoma progression, but in early and moderate glaucoma. In advanced glaucoma, as told earlier, the floor effect will be present, so GCC can be done. But for RNFL there is a progression software, but for GCC there is no progression software as of yet. So mainly advanced stage, follow up with visual fields only. Structural changes precede functional changes in early disease and vice versa in later stage. This is a guided progression analysis. This is progression software in Cirrus HD OCT. In that, the 2 baseline in OCT scans should be there. After the 3rd to 4th, this GPA can be done. So the machine itself will analyze the values, every values, and will tell if there is glaucoma progression or not. It checks the average RNFL, superior and inferior RNFL thickness, and the average cup to disc ratio. All these are plotted, and the machine will analyze. And in the summary box, the machine itself will tell if there is possible progression or probable. It's not upgraded in our